Second. Okay, so today we're going to talk about documentation and write it right. This is not always a very exciting topic, but it's something I'm very passionate about. My background is I've worked in risk management. I've worked at a malpractice insurance company for physicians. I've worked as a testifying in court, writing reports for as an expert witness. So I understand, and helping to prep nurses for depositions prior to meeting with attorneys if they were asked to come to provide a deposition. So just want to hope you'll glean some new information from today's presentation. So today the objectives I'll describe how documentation affects care outcomes, regulatory, financial impacts, and the quality of care. We'll identify consequences and effects of not documenting and distinguish pertinent information to document. So from the care outcomes perspective, documentation is important because it's providing that record of care that's delivered to the patient. It's showing the continuity of care, the outcomes of care. It's important to have an accurate record. And now that most locations or at least big health systems are electronic, it's used across the continuum. There are still facilities who are not electronic and still on paper, but for the most part, many of the electronic charts can show different views, whether you work in the inpatient or the ambulatory emergency department, you can toggle through the views. It's true, the EMR has increased time demands, but it's not an excuse. It's not an excuse to not document. And some consequences and effects of not documenting. If it wasn't documented, it wasn't done, is the old adage we always say. And that can affect reimbursement to your facility. It can affect referrals. It can affect that the patient has to get repeat testing completed. From a patient safety perspective, if you have gaps in the medical record, you're not going to see what your patient outcomes are. And based on what treatments were ordered, what medications were administered, it can cause delays in care, and it can also cause duplicate care. If you look at the financial impact, there are compliance standards. Center for Medicare and Medicaid, CMS, has conditions of participation, and there are specific criteria that we must have in order to be paid. And that's in order to charge for a procedure, you have to have documentation that it was done. So if you do an EKG and there was no order for it, then your facility cannot charge for that EKG because there was no order and there was no, or you would have the documentation was done, but you need to have the order in order to be paid and know that it was completed. It's important from a financial perspective because it can be used in court as evidence of care provided. So for instance, in a professional malpractice, professional negligence or malpractice case, this can affect the outcome. You know, we may, if the defendant is held liable, then, and they have to pay a certain amount of monies, maybe because there was good documentation, there would be less money that would be paid out. From a financial impact, this can also affect disability determinations for patients, workers' compensation care, domestic and child abuse, and also the competency or capacity determination. If a patient, if you're getting a psychiatry consult or the patient's being determined whether they have the capacity to make decisions, and we're looking at whether they need to have the POA, the power of attorney, then they would have to, we want to make sure that whoever's going to be handling their finances has the documentation to prove that their father or mother does not have capacity, so they would have to take over this and make sure that to have the finance taken care of. Sorry about that, messed it up. From a finance perspective, it's going to decrease exposure to litigation for compliance, risk, and liability issues. And the consequences and effects of not documenting, again, if it wasn't documented, it wasn't done. We talked about the malpractice and the workers' compensation verdicts. It can affect the future of patients in abuse cases, and again, the competency and capacity for decision making. When we look at the regulatory impact, there are documentation standards. A federal documentation standard is in the Code of Federal Regulations, and it validates continuity and quality of care from entries made in the medical record. That's the definition. Our state nurse practice acts evaluates the response of patients to medical and nursing interventions and involving appropriate team members in the evaluation when warranted. And then the Joint Commission states it's including information to identify patient, support the diagnosis, justify the treatment, and document the results accurately. So we're looking at those different types of standards when we are standard definitions for documentation. There are also national nursing organization standards of care. We have the American Nurses Association, AACN, we have the CEN, or any of your specialty nursing organizations, ONC, RNC. Those are standards of care that we have to follow. Organizational policies. Every different area in a hospital, if it's an inpatient, ambulatory location, a specialty area like labor and delivery, the OR, the emergency department, they all have different standards of care because you all treat your patients differently than, from one to the next. And also your organizations will also have policies that are specific to documentation of what you need to write, when you need to write it, and the location to document that. So some consequences and effects of not documenting. Again, it's going to affect your compliance and the ability to bill. It may affect your Joint Commission or your DNV accreditation, depending how you are accredited, if you are accredited. And then the nursing national standards are not followed, and that can impact the care that you're providing because you may not be providing evidence-based practice. From a patient safety perspective, care provided may be out of scope for the nurse, and we talked about the standards of care not followed, so evidence-based practice may not be followed. Looking at the quality of care, it's important to provide that patient-centered care. We need to have documentation so we can send the patient to the next referral. Maybe they need to go see a specialist. Maybe they need to see an oncologist. But it's important to show which tests were done, what the physician or provider orders and notes state, so that when that patient goes to that specialist, they'll have as much information as they possibly can to get a good history on that patient so that they can treat them and take them to the next step. It's important that we have the documentation for authorizations. Many insurers require that we have to get pre-authorization, say for an MRI, a specific specialty medication, and we need to show that this test was done or this medication was ordered prior to that patient being able to take on the one we're trying to get them to have, the specialty med. Patient satisfaction. So documentation is important for that patient when they go home. Are the discharge instructions clear? And what is the education plan and information that's provided to that patient? The quality of care also is fulfilled. This fulfills a regulatory requirement, like we mentioned. And then it's ensuring the quality of care through the written and electronic communication. From a value-based purchasing perspective, hospitals are getting reimbursed based on, no readmission within 30 days, no hospital acquired conditions. We can show how we're caring for our patient by, documenting what we've done based on the bundle for CAUDIs or CLABSIs. So it helps with that. It assists in establishing and following those standards of practice. When you document, this data may be used for research, and data may also be used for a quality improvement project or a quality measure. So some consequences and effects of not documented, it may show poor or inconsistent care has been provided, decreased patient satisfaction, and then there's the big effect on reimbursement. But from the patient safety perspective, it may cause delays in care because maybe the patient, things were done, procedures were done, tests were done, or conversations were had with a provider who didn't document something, and that may delay that patient's care. Maybe they're following the incorrect treatment plan, which meds they should take. So it's important to have the most up-to-date and accurate information. Documentation challenges. So many locations, most locations are on electronic, like I said, but there are still areas in those facilities that do use paper. Those of us who started on paper many years ago and moved on to the electronic medical record, we're very comfortable with paper. But it's easier to write on paper than it is to toggle through the different screens in the EMR. So maybe we'll find a reason to use paper instead. The comprehensiveness of charting may be lacking due to flow sheet incompatibility, whereas before, when I worked in the ICU, we had, the quadruple fold out paper, and, we could easily see the trends of our patient's heart rate, blood pressure, rhythm, whereas it's a little bit more difficult in some of the electronic medical records. If you're going into a patient room and you're doing a blood glucose, you're giving meds, you're doing vital signs, you're doing an assessment, it can be difficult to chart everything at that point of care just because you're doing everything at once. Difficulty accessing other views. If you do work in a different area, say you work in the inpatient and you want to go look at the ambulatory view to see how that patient has been doing with, they've seen their provider or what happened. Maybe they came from the doctor's office over to the hospital, and there was an urgent incident. You can find out what happened. You may not have that ability to look for the different views. And then there are people who have limited typing skills, which is frustrating for them, and they don't like to type for that reason. So now we're going to talk about what to document. I don't know if any of you have ever felt this way, where you feel like your brain won't turn off, and then you remember, oh, I forgot to chart that 4:30 p.m. narcotic, and now you're wide awake. I guess I've been there. I'm sure many of you have too. So what to document? Your assessment. It's important that you document your assessment. You do the assessment, your findings are important, and it should be documented. Whether you do it just an initial assessment in the morning or at night when you first come in, or whenever you do an assessment, maybe the patient's having an issue and they're starting to have a flash pulmonary edema, and so now you're reassessing their lungs and respiratory status, and document that information. The patient history is important, as well as allergies. And sometimes patients will come in and they'll say, oh, I'm allergic to Vicodin, I get nauseous. So you would put down that the patient stated their allergy was Vicodin, but it's important to say what the effects are, that they're nauseous, versus having, it's important to show that that person's having hives, that they had an anaphylactic reaction in the past, what happened. So do that extra step and complete that. Provide just the facts, not your opinion, not someone else's opinion. You want to document what you saw, what you witnessed, what you observed, what you assessed. If someone came up to you and said, this is what happened and this is what the patient said, you wouldn't document that. You would go directly to that patient or family member and ask them about the issue. If you have interpreters that you use at your facility, if you use the iPad or if you use the interpreter phone, it's important that you document the operator number so that we can always go back to see that you spoke to operator number 12345 on January 19th at 3:45. So that if anything ever happened that we needed to reach out to that person for information, we would always know who that person could be. If we have interpreters who are in person, sometimes we use facility dependent interpreters, where interpreters are certified at the facility to be used throughout the hospital. You would document their name. If it is a family member, such as the wife, or if it's a child, you would want to write the child's name down, because maybe they have 6 children and there are 6 girls, and you just want to be able to distinguish who that was. If you use interpreters from external, like for those who use the sign language interpreters, we would also put their name as well. And again, you want to document your observations. You want to use quotations for patient and family statements. If the patient states, every time I wear these high heels, I seem to trip and fall, and they fell, and that's what you found them, you saw them fall, or you found them on the floor, you would want to make sure that you documented that information. You want to document patient complaints. There are different rules for a complaint versus a grievance, so having good documentation is important. Chart as you go and try to be as chronological as possible. Now, if you're in the middle of an emergent situation and your patient's crashing, you are not going to document, worry about documenting. You're going to take care of that patient and document after that patient is stabilized. But try to be as chronological as possible. You can add a late entry or an addendum to a medical record. Electronically, it's just going to pop up with the date and time that you enter that information. If you're doing it on paper, then you would just have to write the date that you're entering. So if I had a patient on Monday, that was the last time I was into work, and I remembered that I forgot to chart the dimensions of the wound, that when I had done the wound dressing, I had measured everything, and I forgot to chart that. I would go back to Monday's note. I'd put today's date and time and put late entry or addendum, and then put my assessment in there. If you have the opportunity to document an electronic incident or event report, or whether you write an event report on paper, it should be a clear summary of the event. It should not have opinions. It should not have complaints. For the example of the lady, of a female who fell wearing her high heels, saw a patient ambulating in hallway, patient fell, patient stated, every time I wear these high heels, I fall. That would be something we would put for that. You want to document education and instructions provided. Now, some EMRs have a specific band where you can document all this information, and some may just have a more global location for you to document the education. And on paper, if you're paper charting, then you would know where to chart this. But you want to talk about what topic or material you discussed with the patient and or family. What type of education did you provide? Was it verbal information? Did they watch a video on the TV in the room? Did they watch something on the iPad? Was it a group setting? Did they do any teach back? They want you they're learning to do Lovenox injections, so you want them to demonstrate and provide that teach back opportunity. You want to document who was educated, if it's just the patient or if it was a family member, if they've had any questions or answers, and then acknowledgement of that patient and family member, that they understand the education and instructions provided, and give them the opportunity to call back if they have any questions. This is true. When I eat too much dessert, I don't post about it on Facebook, because if it isn't charted, it didn't happen. So just a little bit of humor there. When we look at what to document from when the interventions are provided with or without a physician order or provider order, what happens when we have face-to-face or electronic exchanges and verbal orders, we're going to talk about this over the next few slides. So when you provide an intervention with a provider order, then you want to make sure you document it. If you administer a medication that is ordered and you want to document that you gave that order. If you do something without a provider order, something like ice applied, extremity elevated, patient, turned in position to comfort, something, you would want to document that. You want to look at their response to the intervention. What does the wound look like? Is there any tunneling? Did you measure it? Is there any exudate? Be very descriptive about your wound. So they can compare it as they go from day to day throughout the hospital stay or facility stay. What's their respiratory rate like now that you've applied oxygen? What's their heart rate like now that you've given them a medication to help lower their heart rate? And pain assessment post-medication administration. This is very key for those who do get accreditation by the Joint Commission. I'm more familiar with that than I am with the DNV accreditors, but they always look at, what is your pain reassessment? If you administered that oral medication, did you document 1 hour later per your policy that patient's, the level of pain since they've gotten the medication? Or if you've given an IV medication, did you document 30 minutes later what that patient's pain level was to see if that is working or not? Changes in condition, escalation of care, and chain of command concerns. The Joint Commission is very concerned that you do have a policy in place for these issues. Because we want to make sure the patients are getting care, and there's a process for the nurse to get what they need for that patient. So if the patient has a change in condition, you're going to document your assessment and the actual changes noted. You're going to document the name of the person notified and be specific. So if you're working at a big teaching facility and you want to put resident notified, you really need to be specific. So my first job was at Crozier-Chester Medical Center in Chester, and we had many different service lines. We had 3 different groups under the medicine service. There was the red group, the blue group, the yellow group. One was ID, one was medicine, one was oncology. And on night shift, only 1 intern and 1 resident covered all 3 services. So it was important that we would put the specific name of the person who we spoke to. You want to put the time the discussion occurred and the content of the discussion. Informed provider, patient's blood sugar was 40. Juice provided, repeat blood sugar still shows blood sugar is 60. So what interventions did the provider want you to do, and what follow-up was provided? So again, if you do, I would look at your facility at your escalation of chain of command policy. This is important because if you can't get a hold of that intern or resident, if you do have them at your facility, then you have to call the attending. And then if the attending doesn't answer, then you might have to call the chief of the division or the chair of the department. And if that person doesn't answer you, then you might have to call the chief medical officer. So there should be a policy on who to call if someone doesn't answer you. Verbal orders are based on the institution and who is able to take and give verbal orders. So physicians, residents, LPNs, RNs who are not on probation or orientation, nurse practitioners, physician assistants, pharmacists, respiratory therapists, licensed dietitian, nutritionist, radiology technologist, diagnostic medical sonographer, and nuclear med technologist may all be able to take verbal orders at your facility. It's important to know that if you're going to take a verbal order, it has to be related to your scope of practice. So an LPN should not take a verbal order for an IV push medication because an LPN cannot give an IV push medication. A respiratory therapist would not be able to take an order for a radiology study because that's not within their scope of practice. So just be cognizant of that. Verbal orders are strongly discouraged. It's very easy to say, oh, can you get an EKG in room 26? And can you get a CBC in room 12 for the provider to do that? And we don't want to encourage that. We want them to write the orders down. Whether we were doing it on paper charting years ago or electronically, they need to enter the order in so that we can do the procedure, the test, med, etc. Verbal orders really should only be used for urgent issues, but not all the time. If you do get an accrediting body, they will look at your verbal orders, and if they start to see a lot, then they'll look at that a little bit more closely and wonder why there are so many urgent verbal orders. Now, the provider, the surgeon may be in the OR, and they're giving you a verbal order, and someone's pulling the phone out, and you're having a conversation with them, and they're telling you what the order should be, and you repeat it back. Or they may be driving in their car, they may be at home on call. So those are pertinent for verbal orders, but not for someone who's walking down the hallway that can easily enter the order in themselves. A good practice to have is to repeat back the order. Again, Lasix 40 milligrams, IV push now. And the provider will say yes or no. And the provider, when they come back in to the hospital or your facility for the next time they're in, they will need to sign, date, and time that entry. And your facility will say how many days it is that they have to do that. Might be 2 days, might be 5, might be 7. Some EMRs will lock them out and will not allow them to add any other orders until they do sign that. So sparingly use verbal orders. When we look at critical results for studies and tests, critical results don't just apply to lab tests. It applies to radiology studies or images, cardiology studies, and any respiratory therapy critical findings or results. So Joint Commission National Patient Safety Goal number 2 is improving the effectiveness of communication among caregivers. National patient safety goals for the Joint Commission have to be followed 100% of the time. And we really want to make sure that these critical results are followed up in a timely manner. Many facilities make sure that once they get that critical lab result or critical result, that they call the ordering provider or call the nursing unit to provide those orders, to provide the information. And then the person receiving the study results needs to then call the ordering provider or whoever's on call within a specific amount of time. And it's usually around that 1 hour time to get everything completed so that patient can be treated promptly. And you'd have to look at your institutional policy to see what that looks like for you. So if we have protocols, protocol usage must be based on condition-related orders. And I'll talk about some protocols on the next page. Protocols are written based on evidence-based practice, and they must be CMS compliant, Center for Medicare and Medicaid Services compliant, and they must be written and approved by your hierarchy at your facility, whoever's doing the approval, signing their names on the policies and protocols. We often like to say, oh, our protocol is this, our protocol is that. But the surveyor, whether from the Department of Health, Joint Commission, will say, show me your protocol. So it's important that you have it in writing to be CMS compliant. You don't want to chart care that was ordered but not provided. If you sign off that you gave that medication, but you didn't, that's fraud. And the hospitals can be fined and lose their ability to treat Medicare and Medicaid patients by doing that. So we don't want that to happen. That's very extreme, but you shouldn't sign off your medications before they're administered. Your policies will have specific criteria for specific situations. So you will probably need a second RN verification for narcotic wasting. If you're administering chemotherapy, you will need a second RN to review that. And looking at your high alert medications such as heparin and insulin, you may need to have that second RN verification and a signature. And this means actually, watching your coworker waste that narcotic, checking side by side with your chemotherapy and your other medications. Your follow-up pain score, like we talked about before, if you're administering a medication to that patient, what is your policy on when you need to follow up to check, to reassess? Your plan of care, this may be done once a day, it may be done twice a day, but you need to follow whatever the policy is for your plan of care. Your falls assessment, is it only done once per shift? Is it done once per day? Is it done every 4 hours? Your findings on reassessment, again, you may have your assessment initially in the morning or in the evening when you first, or night shift when you first come in, and then how often do you have to reassess? Like, every 4 hours, 2 hours, etc. And for those patients who have epidurals, there are specific vital signs you would be taking for them, respiratory rates, and so that would require specific documentation as well. If there are any medical emergency responses, your code sheets, your rapid response documentation, it may be electronic, it may be on paper. Just know you would need to complete it based on whatever the policy is at your facility. So when we look at the relationship to the State Board of Nursing, for those of you, it's probably been a few years, but they used to put out this little green book for the State Board of Nursing that had Title 49, PA Code Chapter 21, State Board of Nursing. Now it is all electronic. But I just wanted to just show you this as part of the responsibilities of the registered nurse. So it talks about from a general function perspective, the RN is going to collect, complete, and ongoing data to determine the nursing care needs. They're going to analyze that data and to determine the nursing care needs, identifying goals, their plans, their nursing care plans, carrying out those care actions involving individuals in health, maintenance, promotion, and restoration, evaluate the effectiveness of the quality of nursing. And essentially, so when we're collecting complete and ongoing data, we're documenting that. We're analyzing that data from what we've documented. We're putting in our goals and care, the goals of the patient and the care plans. And carrying out the nursing activities are, you're giving your medications, doing your treatments, walking that patient in the hallway. So this is just showing just an example of how documentation is part of what we always need to be doing. And another example, this is under the venipuncture and IV fluids section. If you look where the arrow is, it says an accurate record is made concerning the following: the time of the injection, the medication or fluid injected, the amount of medication or fluid injected, and reactions to the fluid. So the State Board of Nursing is also saying we need to document. Abbreviations. From the abbreviations perspective, when we would hand write our notes, or providers would put orders in, sometimes handwriting is not legible. So when the Joint Commission was going around and doing their surveys, they finally made a list. Now this is probably at least 10 years old. And this is the official do not use list. So for handwriting, we should not be using this. And we really shouldn't be using it as we type in the EMR either. But The U's, the capital U or the small u, were abbreviations we used to use for units. And sometimes they were mistaken for a 0, sometimes they were mistaken for a 4. So instead of giving 4,000 units of heparin IV, they may have received 40,000 units of heparin IV just because they couldn't read the handwriting. The trailing 0 and the lack of a leading 0, maybe 0.7 milligrams was ordered, but maybe it looked like 17 milligrams, and they didn't put the 0.7. And then the morphine, MS, we would document that, or MS04. But sometimes the MS04 and the mag sulfate get confused. So these are just some examples, and then this would be at all of your facilities that do get the Joint Commission accredited, that you don't want to use these. Before we skip there, and your facility should also have a policy on approved abbreviation, and you should be aware of what they are. I remember reading a note at one of my facilities, and had patient using RW. And I was like, what is RW? I couldn't figure out what RW meant. So I looked it up, and it was like rolling walker. Well, I had never ever in any of the facilities I ever worked at used that term or seen that term, but that was an approved abbreviation there. So if you're not sure, you should be able to find it on your internet or in your policy, in your manuals. Okay, what does all this mean? Dana, I'd like to see if anyone would like to give a stab at reading this. I feel that some nurses don't document this way as much anymore. So I was wondering if anybody would want to volunteer, and Dana can choose someone to read this out loud for what this note says. Anyone want to volunteer?
Any volunteers?
I'll take a stab.
Okay, go ahead, Megan.
It's an 84-year-old female patient from the emergency department with a past medical history of COPD. So congestive obstructive pulmonary disease, congestive heart failure, hypertension, diabetes, atrial fibrillation, past surgical history of coronary artery bypass graft ×4. Then I lose it for a little bit. We have a history of VRE and MRSA. They'll need a PIC, a chest x-ray, a type and culture, and then packed red blood cells, ASAP or stat.
Okay, great.
I think that's a right total knee replacement and a left total hip replacement.
That's right. Very good, Betsy and Megan. Thank you for volunteering. Great job. That's extreme nurse charting. We probably won't see this, but I just, there are ways to document. There's a way to make shortcut documenting when you're documenting, but this is just an example I thought was a fun one to share with them. So thank you for your participation. Looking at standards of care and documentation, they're going to be facility dependent, specialty dependent, and expectations will be different at your different facilities. So the standards of care are how often you do your assessment. So the focused assessment will be done at the beginning of the shift. If you work 12 hours, maybe 8 hours into the shift, or every 4 hours. If you work in the ICU, it may be every 2 hours or every 4 hours. If you work med surg, it may be once an 8-hour shift. If you work in labor and delivery, it may be different. But your standards of care tell you how often you should have your assessment, do your assessment. It tells you how often you should document. Now you can always document extra, but if there's specific flow sheets that need to be filled out, like once per day, once per shift, twice per shift, etc. How often you should take your vital signs. Is it once a shift, every 8 hours, every 6 hours? It's based on your specialty. on your unit. How often our rhythm strips need to be identified. Is it once per shift, every 4 hours? Who documents on them? And also, we talked about earlier, your care plans will tell you how often you'll do your care plan. We look at policies, protocols, and guidelines. I just want to share briefly with you. Policies communicate the values, philosophy, and culture of the organization. It provides expectations for the employees, the employer, the community, explains the rule, but it doesn't state how to put that rule into action. The procedure will tell you the why behind the action. So an example might be your suicide risk assessment policy. So it's going to talk about every patient who presents to the emergency department will be screened for suicide risk assessment. Every patient who enters the inpatient, gets admitted to the inpatient, will have a suicide risk assessment. And based on the location of where you are with that, where that patient is, it will talk about what tools you have to get to that patient, the procedures, the procedure you will follow for that next step. We look at protocols. We talked about that a little bit earlier. So this is a process allowing clinical staff to carry out a specific set of orders based on that patient's condition, their clinical setting, or their diagnoses. It's essentially the who, what, where, when, and why. Evidence-based with national standards. You need to document protocol use in the medical record, and it might be order specific. So the provider may order, a heparin protocol, and maybe a low protocol, or maybe a high protocol, and based on what they've chosen or ordered, you have to follow. How much will you give heparin bolus, or will you shut the infusion off? When will you recheck the labs, etc. And the same thing for insulin. Other types of protocol examples are EKGs. So if a patient has chest pain, you can do an EKG. If a patient has urinary retention, how often can you do the bladder scanner? How many hours do you have to wait until you can do a bladder scanner? Based on specific criteria for that patient. Foley catheter removal. Maybe your patient is post-op and it always gets removed on hour 24 post-operatively. Whatever evidence says, whatever the facility has agreed upon is what they want for their protocol. Diabetes care also is important, maybe because you're going to have your hemoglobin A1C every 6 months, or your foot care or your eye care. Just, having that ordered for you so you can continue on with your care. Clinical practice guidelines are general recommendations. They are not required and they are not mandatory. Again, these are also evidence-based and they come from national standards, but this is where you're going to use your clinical judgment and adjust it based on that patient's condition or need. So maybe it's a post-op joint patient and they're supposed to be out of bed, hour 2 once they've hit the floor, and they're supposed to be out 3 times a day, but maybe they're having difficulty, so they're not going to be able to do that. So how can you adjust the guidelines for getting that care and to be for that patient to ambulate? Now we're going to talk a little bit about professional liability. So when you have an event and you document on an incident report or occurrence report, I use those terms: event report, incident report, occurrence report. They're all the same to me. They may call them something different at your facility. What you're not going to document on them, you're not going to document complaints about staff and providers. It may be that every time you call that provider, that they don't call you back and you have to call them 6 times. Or it may be that they're, they don't want to respond. They'll respond and they'll say, it's not important. Just don't bother me again. You're not going to document this information, that kind of information in an incident report. You're not going to document your dissatisfaction. This is typical behavior of him. I knew this would happen. That's why this patient had this issue. You're not going to document that information. Don't hypothesize what happened. I bet the patient probably became hypotensive and that's why they fell. we should not be hypothesizing. Don't provide a diagnosis or how that patient's condition may be in the future. Oh, they fell, but they're okay. They'll be fine. We shouldn't do that. And don't make any assumptions. So what you do want to document on your incident report or event report is the type of incident. Was it an injury? Was it a near miss? Was it property damage, equipment issue, or was it an infrastructure failure? So for a near miss, we want to make sure that if pharmacy sent up the wrong medication dosage and you did not administer it because you went through the medication rights and you didn't administer it and you called pharmacy and they sent up the correct dosage, you should still fill this out, because, and I've had people tell me, well, that's just going to get someone in trouble. No, it's not, because we're looking at system issues. Maybe the medications are side by side and they pulled the wrong one. You didn't give the medication, you followed what you should be doing, and that's fine. But we want to look at a system issue. So it's important to document those near misses, because maybe it happened on your floor and maybe it happened on 3 other floors throughout the facility. If you have an equipment issue, you want to make sure that you document the serial number, what happened to it, any other kind of like biomedical information that you have on that, and your infrastructure failures for no heat, no water, no phones, that kind of information. Be descriptive about what you witnessed. So if you go into a patient room, you were walking by and you happen to see someone lying on the floor and they were supposed to be on bed rest. They got out of bed without calling for assistance. And when you found them, they were still connected to their sequential compression device pumps, and they could only get so far with them, and that caused them to fall. So, you would, found patient lying on left side, sequential compression boots intact. Patient stated, I didn't want to bother anyone. I thought I could do it by myself to get to the bathroom, left wrist showing deformity, patient assisted back to bed, provider called. So you would be very descriptive about what you assessed. You'll document that patient's contribution to the incident. Just like I said, the patient stated, I thought I could do this. Using the quotations, were there any witnesses? Did anyone else see the patient fall or what they were doing? What was the response to the incident? Are they complaining of any pain? Are they, now they're more confused? You need to document which provider you notified, if you notify your supervisor, et cetera. And you want to document the incident in the medical record. So incident reports / occurrence reports / event reports are not part of the medical record. So if you only fill out the incident report, no one will ever know what happened if you don't document it in the medical record. Okay. In Pennsylvania, and we also, I should have put this in what not to document, do not document incident report completed, because in Pennsylvania, the plaintiff attorney is the person who would be suing. They have to specifically ask for them, but if they don't really know to ask for them, then they don't get them. But if you have it documented, they'll say, oh, I'd like to have a copy of that, and we would have to give it to them. So when we look at documentation and how it's used in legal proceedings, it is used in malpractice or professional liability. It is used in abuse cases, and it's used in the disability cases like I mentioned before. Okay, I have a little quiz here. So the statute of limitation to file a lawsuit, there's a very specific amount of time that you can do so. So Dana, I would like everyone to tell me in the chat how many years you have to be able to file a lawsuit in Pennsylvania. And Dana's going to monitor the chat and just let me know what some of the responses are for the adult.
5, 10, 7, 2, 10, another 7.
Okay, Great.
7,
7 seems to always be a very popular number when I ask this question. So the statute of limitations to file a lawsuit is 2 years in Pennsylvania. It's 2 years from the date you found out the incident occurred. So if today the patient was scheduled for a right below the knee amputation, but they had a left below the knee amputation, it's 2 years from today that they could file a lawsuit. If it's someone who, I always like to use this example, I had a C-section with my daughter, and then all of a sudden, 22 years later, I'm having severe abdominal pain, and I've never had any other abdominal surgery except for my C-section. And they do a flat plate of the abdomen. They find a sponge with the Raytech sponge in there. And the only way it could have gotten there was that surgery 22 years ago when I had my C-section. It would be 2 years from today that I could sue. Now, how about children? If anybody wants to put the number of years a child can sue in Pennsylvania.
so far we have children unlimited or 18. Then another 18. No idea.
Okay, great. Thank you. Thank you, Dana. Thank you for all your responses as well. In Pennsylvania for children, it's 18 plus 2 years. But if the parents have sued for that child already at age 10, then that child, when they get to age up to 20, cannot sue again. So thank you again for your participation. In order for negligence to be awarded, there are 4 components to that. There's duty, breach of duty, injury, and causation. Duty are following your policies, following the standards. Breach of duty is you didn't follow them. Injury, an injury happened, and we can show causation that by not following that policy, an injury occurred. So if, and one quick example is if the duty is you were going to go and start an IV on your patient, you put the side rail down and you didn't find a vein on the right side, and you went to the other side, you put the side rail down and you went looking for a vein on the left, you found a good vein, you realized there are no gloves in the room. So then you ran across the hallway to grab gloves. And when you walked back in the room, the patient was on the floor with, an externally rotated leg. So the duty is we keep our patients safe. We always keep the side rails up. The breach of duty is we didn't keep the side rails up. The patient fell out of bed and therefore suffered an injury. So that would be an example of negligence. The other example I like to give is when I worked at a malpractice insurance company for a physician. Some of the malpractice rules were a little different back then, but still this would not have applied. A female patient wrote to us and wanted us demanding money for her broken toe that she said was not treated correctly. She broke her second toe, went to her orthopedic surgeon who said, yeah, just buddy tape it to your third toe. It healed without incident. A few months later, she went to her podiatrist, and the podiatrist said, oh, that's malpractice. That's not the standard of care. You should have taped it to the big toe. And so in this instance, and she had no injury. So the duty for this issue was we're going to buddy tape the toe, which she did. That's what the surgeon told her. Did he breach the duty? No. Was there an injury? No. Can we show causation? No. So that would not be considered negligence. So to talk about some use of nursing notes, how they're used in professional liability cases. Can't see the top of my screen there. So they're going to be used for the patient to be able to review their medical records, because patients are able to get their medical records. Sometimes as a patient, there might be specific situations where a patient's not able to get them directly, but that's dependent on your facility. Such as, a patient like a psychiatric facility may have different regulations than other facilities. The plaintiff attorney may review them prior to initiating any lawsuit. Patients come in, or clients come in, they tell you what happened. And when you look at the medical records, they don't really have, that's not really what happened. If there is a lawsuit, the defense attorney will review the nursing notes. Risk management will look at them. Patient safety will review them. If a root cause analysis is done, it'll be reviewed. If it's a situation where it's a really bad case and the facility knows they're going to be sued, the defense attorney and risk management may look at them and figure out offering a settlement out of court. They're going to look at the incident report that was filed and compare it to the nursing note. What does it say? Does it say the same exact thing? It really should say the same exact thing. It'll be used in a deposition. And when I worked in risk management, I would help prep nurses for depositions prior to going to meet with the attorneys. And essentially, you know, you had to go back and look at your notes from 3 years ago. Would you be able to tell what kind of care, anything about that patient that you provided to that patient? It's very, at the time, the attorneys that we worked with, they would only let the nurses look at their own note and not go look through the chart at all. So it was very focused to only what they provided. And then these notes will also be used in court. And years ago, they used to blow up, you know, they had the tripod and they'd have the big poster of all the nursing notes, but now they just have a big screen and they just post it that way. So just to quickly summarize, documentation needs to be relevant, complete, timely, accurate, needs to be compliant from a regulatory standpoint. It should follow your policies at your facility, and it should be factual. And then I know we're around at time. I want to know if anyone has any questions that I might be able to answer for that. I see Dana put the evaluation form link there. You can either put the questions in the chat or you can unmute and just ask me.
This is Marilyn Harris. Just a comment, everything you said is so relevant. Over my career, I have done those reviews always on the side of the patient because that's who I want to defend is the patient. And the one that really I never review in Pennsylvania. I mean, it was always some other state. And the one I remember was the patient died and the family was suing and there was no excuse. They were doing INRs regularly. Somebody was checking that they came back, but nobody looked at them and the lady bled out. I mean, sad. I mean, it's just so important to follow through, not only on the test, but the results and the reporting and getting. So if any of you want an experience, offer to become an expert witness and go through some of those depositions. It's a traumatic time sometimes, but it's true.
Thank you, Marilyn. I see Megan said, as a student nurse graduating this semester, documentation can be overwhelming. Yeah, but it is very, but you know, get into a routine where maybe you're going to, you know, do your patient assessment and then document and again, then give your meds, or maybe you're going to, you know, do your assessment, give your meds, and then do your documentation. But whatever flow works for you, it's just important that you do document your findings. Okay. Anyone else? All right, well, I appreciate all the time you took today for this presentation. If you have any questions, let me know. And again, so Dana, do you want to say anything else more about the survey?
Just thank you so much, Deb, for presenting. That was awesome. The survey link is in the chat. I will also email that out to everyone. So make sure you complete that survey so you get your contact hour. And then just keep an eye out for our next Coffee and Connect. We are hoping to have more contact hours at our next session. So I hope you all will join us again.
Thank you.
Everyone.
Thank
Have a
you.
great rest of the day.
Thank
Bye-bye.
you.